Thank you, everyone, for tuning in with us. Really excited to present this week's next part of our webinar series, which is on Prozac, Fluoxetine, presented by Dr. Mark Horowitz and moderated by me, Emma, and I'll introduce myself a bit later.
All right, end of a long day here, but I'll bring it home with Prozac. So do I control this? So maybe I'll introduce. So Emma is our growth and partnerships leader at Outro, and she's come off Cymbalta, so she's not just a theoretician here. And I'm one of the co-founders of Outro, and I work as a clinician in the National Health Service in the UK, in England, and a researcher. And I've come off a few antidepressants, including Lexapro and Remeron. So we're going to talk today about a few things. Why do people want to stop antidepressants like Prozac? What are the trouble they have when they try to stop? What are withdrawal symptoms? What causes them? What is this technique called hyperbolic tapering you might have heard about that can make the process easier? And then talking in a bit more detail about tapering Prozac. That's the brand name of fluoxetine, the drug. And then some time for questions and answers. And so if you've got any questions, put them is it in the chat or is there a Q&A? No, it's just the chat.
Put them in the chat. I have like a separate page open. I'll be multitasking through the presentation. So if you see my eyes moving, it's not that I'm not paying attention to Mark in his presentation today. I'm trying to make sure that I grab all the good questions so that I can save them for the Q&A section. So even when we're not in the Q&A, write questions about the slides or about what you hear from Mark so that we can make sure that we cover as much material as possible in the discussion session. And we'll try to save up at least 15, hopefully 20-ish minutes for that.
Okay.
And we're ready to go.
Okay. So what are reasons that people might want to stop an antidepressant? I think it's good to zoom out on the context of this. So this is American data, although it's a few years old now, where you can see that there's this red line on this graph is people who have been on antidepressants for 5 years or more has been sort of skyrocketing in America, from it being quite rare to now more than 15 million adults. I think that's in 2017. There'll be more than that today. There'll be at least 25 million people in America. For most people, these drugs were intended to be used for a few months. There are issues with that, which we can talk about. But for most people, they were not intended to be lifelong drugs. And yet people have been staying on them for longer and longer for a variety of different reasons. There's more and more polypharmacy. People are on multiple drugs, antidepressants, sleeping tablets, drugs like Lyrica, antipsychotics, sometimes because the side effects of one drug leads to the prescription of another drug, what's called a prescription cascade. And we know the more drugs you're on, the more trouble you can have because of interactions between the drugs, because of accumulating side effects. People no longer need the medication. There's lots of reasons why that might be the case. We know that for a lot of people, the drugs are never effective. The number needed to treat to see one person respond to an antidepressant is about 7. That's been quite optimistic. For some people that the drug does work for, it'll wear off over time. That's called tolerance or poop out. A lot of people are prescribed antidepressants in the context of a stressor in their life: divorce, job loss, loss of a loved one, which will send them into a very bad place. We know that most people will recover from those things in time. And so most people don't have a recurrent severe condition. They have a temporary response to a stressor. Lots of people don't want to be on these drugs long term. They want to try other ways of coping. They want to see whether things are okay without them. And then I guess one of the main reasons is adverse effects. There is a long list of what are called side effects or adverse effects of these drugs, including slightly different for different drug types, but including weight gain, sexual problems, a lack of libido, lack of arousal, lack of ability to have an orgasm, emotional numbing, That's a restricted ability to feel both positive and negative emotions. It can affect relationships, intimacy, sense of self, cognitive impairment, impairments of memory, impairments of concentration, sleep disturbance. In the long term, there's evidence that people who are on these drugs can have an increased risk of osteoporosis, cataracts, strokes, heart disease, dementia, and even an early death, with a debate about the degree to which that's due to depression or anxiety or the drugs themselves, but at least some of that has been attributed to the drugs themselves. When we asked more than 1,000 people why do they want to come off the drugs, the sort of answers they gave were a desire to see if they could live without their medication. So I think there's a real sense that people want to see if they have built up the coping skills, the resilience to deal with life without medication. There's concerns about dependency on medication. People, have that sense when they feel they forget a drug on holiday or they miss a dose or two, they suddenly get horrible withdrawal effects, and they become suddenly aware that they are dependent on this drug. That if they stop it, they get serious issues. I know that in America at the moment, there's all sorts of worrying things about supply chains being affected and people not being able to get their medications, which sort of brings this issue to the forefront of people's minds. They think, if I'm on this drug for many, many years, I'll always be dependent on whatever tariffs are put on or whatever systems rely on delivering drugs. I've talked about the long-term effects, all those potential health effects in the long term. Some people feel better. They feel well enough to be without medication. Side effects I've mentioned. A lot of people feel that the drugs are not working for them. And some young women of fertile age are concerned about the effects on the developing fetus. And it's fairly clear now that being on an antidepressant in the first trimester of pregnancy either doubles or triples your risk of having fetal abnormalities, things like malformation of the heart or other malformations. It is from a very low baseline, so 1 in 1,000 babies have such issues, but it rises to 2 to 3 out of 1,000, still quite low, but increased. So it's a reason why young women may want to stop their medication. One of the issues in America especially is that there's a lack of clinical support, knowledge, guidelines, expertise in how to safely help people come off antidepressants. There's a lot of reasons for that. It's partially because drug companies did studies on people who'd been on antidepressants only for a few weeks. And after a few weeks, when you stop the drugs, most people have mild, brief symptoms. Not everybody, but most people do. The drug companies amplified those studies, and that kind of description entered guidelines. So the guidelines say in America today, most withdrawal effects, actually they call it discontinuation effects, this sort of euphemism, are brief and mild, last a week or two, and you can come off in a few weeks. And if you've been on the drugs for 8 weeks, that's basically true. But as I've said, millions of people are on the drugs for more than 5 years, and that's not true. Once you're on the drugs, we've just published a paper actually today, once you're on the drugs for more than a couple of years, your risk of severe withdrawal effects skyrockets. Your risk of having long-term effects skyrockets. And so what's in the guidelines is almost totally irrelevant to long-term users. And that means there's a very big mismatch between what doctors are taught, like what I was taught in my training, and what's going on in real life. And that leads to people going to online peer support groups. There's a couple examples here. Surviving Antidepressants are famous, the mother maybe of all support groups run by Adele Framer, a force of nature. And then there's a variety of different groups on Facebook, one of which is called Cymbalta Hurts Worse, one of the largest with tens of thousands of people coming off Cymbalta or duloxetine. And people go there because they find that their clinicians, their doctors, their nurses don't know how to get them off safely, and they look elsewhere, or they get into a lot of trouble after following their advice, and they end up on these websites. I think a lot of people find Outro or my work through websites like these.
I was going to ask you as well, for most of the people that come to you looking for support on their tapering journey, have they already been on these online forums looking for answers or other people that represent themselves on a similar journey?
Yeah. So Really good question, Emma. It's exactly. So often people have come to me, they have gone to see their doctor, they've come up in a few weeks, they've ended up in pieces, and they have, in desperation, like I did years ago, typed in, how do I get off my antidepressant into Google, and they found these groups. And suddenly they've had this aha moment. It's not just me. Lots of people have this trouble coming off, this panic attacks, this tinnitus, these shooting pains. Yes, other people on my drug also have them. And that's when people, yes, come to me to ask for help. They read about my papers or my work. I guess I've got to say, Outro, part of the reason why I started Outro is to prevent that happening, so that people don't have to fall off a cliff to work out there's a cliff there, that before they get there, there's a path down. Because once you've already had a lot of trouble, some people recover, but a lot of people can have trouble for months or years afterwards. So, I spend a lot of time trying to erect a sign at the top of a cliff: do not jump off this, go down slowly, which is why I spend a lot of time talking to doctors. But still, it's still hard to get an entire profession to change what they do. So this is actually making the point I made before. So this is, withdrawal is a very common problem. This graph on the right shows you something about the relationship between how long you use the drugs and how many people have trouble coming off. So the x-axis is a very simple study. We asked, Dr. Reed asked, how long were you on an antidepressant before you stopped it? And the top line is, did you have any withdrawal effects at all? That's the round circles and a line through it. And were those symptoms moderately severe or severe? That's the dotted line. And the answer is, if you've been on it for a couple of months, most people don't have any trouble, and if they do, it's very mild. But once you're on it for more than 3 years, 2/3 of people are having trouble coming off, and half of them are saying it's moderately severe or severe. And so the drug companies, so you can't see my pointer. So the drug companies did their study up the left-hand side of that curve, and most Americans up the right-hand side of the curve, and that's where that disjoint is. And so a lot of people that we see in Outro and that I see are people that are long-term users. They've been on the drugs for 2 years, 5 years, or 10 years.
And with the average duration of use increasing every year, right, we're going to see more and more people skewing to that right side, being less and less represented by the clinical trial data.
Exactly. And that's why that red line in that first picture, shooting up for 5 years or more, is shooting up. That's the one that's shooting up.
Yeah.
And people hypothesize, I think it's true from what I've seen, part of the reason for that is, the reason why that's going up and up is because people can't get off their drugs. So in this paper we published today, we found that there's a group of people that have tried 2 times, 4 times, sometimes 8 times to come off their drugs, and they can't. So they end up being stuck on the drugs, and they have longer and longer use. So people are getting trapped. I put a tweet today where I said these drugs are a little bit like quicksand. If you're, the longer you stay on it, the deeper you sink in, the harder it is to come out. And so we found, for example, for people who've been on the drugs for less than 6 months, when they wanted to stop, 60% could stop, but 40% found it too difficult to stop. But by the time they were on the drugs for 2 years or more, 80% of people couldn't stop when they wanted to. So more and more people are being trapped on the drugs because withdrawal effects are so unpleasant, or worse than unpleasant.
I think we should visualize that still using the quicksand and all the metrics from your study together. I think that'd be a good one too. You're the master of analogies in this industry, that's for sure.
That was my tweet. I thought I might get fired for it, but that might happen. And so this is the other major issue. Withdrawal effects are easily mistaken for relapse. So, withdrawal effects can include a whole lot of psychological symptoms: low mood, anxiety, irritability, terror, panic attacks, obsessional thinking, suicidality. Any mental symptom that you can think of occurs in withdrawal. I've seen every variation possible. We know that that's not just an underlying mental health condition coming back, because it happens to people who don't even have a mental health condition. The people have been put on the drugs for the menopause or for pain or even in healthy volunteers. And what happens is someone with those symptoms walks into the emergency department of a hospital or into their doctor's clinic or office, and they say, I stopped my drug a couple of weeks ago, and I'm having panic attacks. And the doctor kind of stops right there and says, well, it's obvious what's going on. You've come off your drug, you've relapsed, you must need the drug. Because doctors have been trained so much to look out for relapse and watch out for it. And so that's top of mind. What they're not as good at spotting is withdrawal effects, because they've been given very minimal education about it, as I was. There are all sorts of other symptoms. So on the right-hand side of this slide are what we call the most discriminatory symptoms. It doesn't mean racist symptoms. It means that it helps discriminate between withdrawal and relapse. So things like electric shock sensations, akathisia, which is this horrible sensation, restlessness, agitation, terror, the sort of thing that can make people want to take their own lives because it is so unpleasant. Dizziness, lightheadedness, vomiting, vertigo, nausea, trouble with coordination and gait, being sensitive to light and noise, etc. All of these things are very typical of withdrawal and not very typical at all of anxiety or depression, and those things can help to distinguish. But doctors are notoriously bad at doing this because of their training, and that's why I think this is a bit of a hidden issue, because in lots of medical notes, people have written down relapse, and so the system kind of thinks there's this horrible epidemic of mental health problems, and don't see this epidemic of withdrawal effects. That's why this has sort of ended up being a bit of a medical, a hidden problem. And there's a few other points here. Withdrawal effects can last for months or years. They can come on immediately in a few days, but they can be delayed by weeks and sometimes months, which also makes things very confusing. Sometimes if you give the drug back soon after withdrawal has come on, withdrawal can go away. But if you wait longer and you develop protracted withdrawal, it can be much harder to get rid of it with reinstatement. Things can be much more unpredictable.
Something else I want to mention while we're here, I just think it's very fascinating because it was something that happened in my own experience, is that if your doctor can't discriminate between withdrawal and relapse, and they identify these side effects that must be related to you not being on your antidepressant because you have rebounding depression or anxiety, a lot of the time too, not just in my case, I found out that doctors often also prescribe other medication to address the side effects of the withdrawal symptoms from the antidepressant, which ends up recapping into the medication cascade, where you end up taking a bunch of other medications to address side effects from the original one, which in this case for me too is like the sleeping problems and the digestion problems and the anxiety. You end up getting put on polypharmacy regimen, not because you need it for the situation, but actually because you're addressing the side effects of antidepressant withdrawal. So I didn't know, Mark, if you want to comment on that as well, but on this slide, I always think it's really pertinent to mention because so many people are on polypharmacy.
Totally. I mean, absolutely. That's such a common occurrence, that exactly someone comes in, they're in pieces because of withdrawal. The doctor sees a worsening mental illness, and they go to their books and they say, for terrible anxiety, give a benzodiazepine, give Seroquel, give sleeping tablets if they've got sleep problems, and they pile on drug after drug. So I have seen exactly what you've just described, that horrifying situation of withdrawing from one drug leads to people being on 5 drugs. I've even seen people being on 10 drugs because often the extra drugs don't address the issue, doesn't address the withdrawal effects because it's not the drug the body's missing, or I think something happens to the body and brain in withdrawal where it becomes more sensitive to other drugs, and so people can react badly to the further drugs, which leads to further drugs. So it can become, an escalating nightmare. So that's very common. Yeah.
One thing I want to quickly mention, since we're on the topic of withdrawal symptoms, and I'd normally want to keep all the questions to the end, but Tracy asked, I think, a very important question for us to openly address, honestly. So it's a less discriminatory symptom, but how do you differentiate suicidality coming up in the withdrawal as a withdrawal symptom versus as rebounding depression?
Great question. This is some people hear about withdrawal, they think, oh, headache and dizziness, what's the big deal? But that's, I think, the 3 big deals here in withdrawal are suicidality, akathisia, and protracted withdrawal. When people say to me, look, why don't I just kind of come off my drug real quick? If it doesn't work out, I'll go back on it, try again slower. I say, it could work out, but it's pretty risky because of suicidality, akathisia, and protracted withdrawal. So let's talk about suicidality. There are cases every year of people taking their lives in withdrawal. I have probably one of the worst inboxes in the entire world because people tell me what's happened to their family members, just to have a bit of recognition of what they've gone through. How could you distinguish? Is it relapse or is it due to withdrawal? There's a few things we've done. One, we asked 1,000 people, what symptoms did you have before you started the drugs? Dizziness, headache, depression, blah, blah, blah. And 3 out of 10 people were suicidal. So they had serious problems when they went on the drugs, as of course people do. Then we asked them, what symptoms did you have when you stopped the drugs? And in that case, 6 out of 10 said they were suicidal. So in other words, in this group of 1,000 people, 3 out of 10 of them had experienced withdrawal effects, suicidal effects, only when they came off the drugs, not beforehand. In other words, for 3 out of 10 people, it was only because of withdrawal they experienced suicidality. So there's no doubt that withdrawal itself can cause suicidality. The way to work it out for an individual is, what is being suicidal? Being suicidal basically means there's a problem in my life that I can't solve. There's something going on. I'm going to be caught embezzling money from my boss. I'm going to be caught out with my family. I've done something very shameful. My life is so awful, it's not worth living anymore. That's what suicidality means. So if someone's suicidal, is that happening in their life? Have they just become bankrupt? Have they lost all their money gambling? Are they in the middle of a divorce? Is there a reason for it? Or have they just come off their drug? If there's no contextual reason, and they've got dizziness and headaches and brain zaps, it's telling a story. This is a withdrawal set of effects versus the story of this is someone's life falling to pieces. So you can often tell by what's going on. And I'll just say a kind of rule of thumb. Withdrawal effects are incredibly common, and relapse is not as common, although doctors are sort of taught the opposite. In my view, it's withdrawal until proven otherwise, because I think relapse is a little bit of a false construct. Most people, when life is awful, get depressed. If you get divorced, if you lose your job, if your mother dies, you're going to be depressed. If it all happened at the same time, you'll be very depressed. The next time a bad thing happens, you might be depressed again. Now, you could call that a relapsing remitting condition, but it's just, I think of it more, when things are bad, you feel bad. I sort of, the gag I make sometimes is you could call a seasonal flu a relapsing remitting condition that occurs, in winter. But we're not so silly as to think that. But a drug company, if they were really clever, they would say that, because then you need to take preventative medication all year round for the exacerbation that happens seasonally in winter. So I do think this construction of depression as this relapsing remitting condition does incline people to take long-term medication unnecessarily. So that's my...
And what would you say too, as like the growing evidence could suggest for women that are put on antidepressants, not because they are suffering or struggling with depression, but for PMDD or for premenstrual situations, perimenopause, menopause, and then when they try to stop taking their antidepressant, they experience depression for the first time. I think that for me was one of the most shocking discoveries so far in understanding too how even if the symptoms of withdrawal are depression or are anxiety, it doesn't necessarily mean that it's what we would pathologize as major depressive disorder or some type of general anxiety disorder, because people who didn't have either of those problems before taking the medication experience it while tapering or while going through withdrawal.
Exactly. So 2 good points. So number one, the PMDD stuff, antidepressants, Prozac in particular, was coming off patent. They had to find a new indication to continue their patent thing. They painted they painted Prozac pink. They called it, is it Seraphim in America?
Questions for the end of this presentation.
Okay, they painted it pink, and they found a new indication. Of course, that before that had been called premenstrual tension. I guess it had happened, since women were invented, but now it's been turned into an illness that they can be treated for. I'm very worried about PMDD treatment, that people are being put on and off Prozac every month for a couple of weeks.
Yeah. I went to an appointment and they suggested, thank God I've already gone through what I did because it was a couple months ago. They suggested that I take Prozac for 2 weeks at a time. Take Prozac for 2 weeks, then don't take it for 2 weeks. So we're going to give you quantity 15 a month. And I was like, I'm hesitant on this. I don't really know where the logic is like in this application.
Yeah. I'm worried that what that's doing is its cycles of being on and off the drug. It can lead to something called kindling. I don't know. It's a bit softened because Prozac's a bit of a longer half life, but I'm a bit worried that that could, yes, have all sorts of unforeseen consequences. And you're right. If people are experiencing anxiety and depression only after coming off the drug, it's clearly going to be a withdrawal effect, not them. So
Yeah.
I think this is all
And
confusing.
before we turn over to the next slide, I just want to raise one point Jenna made that I think we've also taken a lot of note and attention to at outro. She wrote, I think part of what triggers these suicidal thoughts during the withdrawal period are a lack of support from doctors, family members, and friends.
Yep. Well, I think that's sort of a secondary depression that you're really, really sick, and then you're being told it's in your head, or you've got a mental illness, you need to take more drugs. So people can be abandoned by their families and by their doctors, and I think that can make it, it adds insult to injury, and I can see how that would make people even more depressed because they're now isolated, gaslit, sort of shamed.
I think we're ready to move on.
I'll press on
There we
here.
go.
So I guess we talked a lot about the problems coming off the drugs, and so we want to talk a little bit about how to minimize these problems. And so I want to talk about hyperbolic tapering, which is based on the way these drugs affect the brain. Um, I wrote a paper about this a few years ago, and actually our medical director, Brian Shapiro, wrote about it as well a few years ago. The overall kind of picture is this. It's a little bit, try and make sense of this slightly complicated cartoon. On the left-hand side of the top picture A, when you start a drug, that's the blue dotted line, it builds up in your blood and it reaches a steady level at sort of time 2. The black line is the sort of amount of the drug your brain gets used to. So it kind of lags behind and it gets used to the drug. The jargon term is a new homeostatic set point, but basically means you accommodate to a drug. It involves a bit of tolerance, is one of the things. Then at time point 3, you stop the drug abruptly. It leaves your body. Your liver and kidneys chew it up. It leaves your body in a few days or weeks. That's the dotted line kind of going down to baseline. The filled in line is delayed in effect. The brain doesn't just get used to the drug not being there in a second. It takes a while. In fact, studies show it can take people months or years for their brain to readapt to the drug not being there. And now the difference between the shaded the line and the blue dotted line is sort of the difference between what the brain expects and what the drug is giving. And I've shaded it in, and that's what causes withdrawal effects, that mismatch. And because it can take months or years for the brain to get used to the drug not being there, it can take months or years for the withdrawal effects to go away. So in the picture below, in picture B, same story, but now rather than stopping in one go, we're stopping in kind of 4 steps. And that makes it a little bit better. There's still this lag time while the brain gets used to the drug not being as high a dose. And there's still a shaded region, but it's less. Those kind of crescents are smaller. And then even better, if you go down by even tinier steps, then the brain lags behind even less, and there's even kind of smaller shaded regions, so there's less withdrawal. It becomes easier by sort of stepping down from the drug rather than jumping quickly. So to sort of focus a bit on Prozac, how does Prozac work? I think there's a kind of a difference between what does Prozac do and how does Prozac work. So obviously there's a lot of talk about Prozac acts on serotonin by sort of it inhibits the serotonin transporter, builds up serotonin. That's what it does. How does it work? I think that the evidence is that antidepressants like fluoxetine work by causing emotional blunting for most people. When you survey people on antidepressants, the vast majority say they feel emotionally blunted. That means that their positive and negative emotions are squished into the middle. If you're very panicked, very anxious, or very depressed, it could be a relief to have your symptoms turned down from a 10 to a 3. It's not the same as fixing a chemical imbalance in the brain. People are often told these drugs are like insulin for diabetes, fixing the underlying problem. I don't think there's any evidence that's true for antidepressants. People maybe are aware that this idea that depression is caused by low serotonin has been essentially debunked. That's not really what's going on. And so I think it's this emotional blunting effect that's why people might think the drugs are helpful. The risk of withdrawal, Prozac has this reputation of being lower risk for withdrawal. That is not really what studies show. Studies show that about half of people have withdrawal effects similar to other drugs, maybe slightly better than some of the SNRIs, but not a whole lot better than other SSRIs. So Lexapro, Celexa, they're all in the same kind of territory in terms of risk of withdrawal. The reason why the drug has this reputation is because the manufacturer of the drug was very clever, very tricky. And what they did was they ran a study where they took a whole bunch of people off their antidepressants for a week and then put them back on their drug. And for drugs like Paxil and Celexa, people had severe withdrawal effects. But for Prozac, they didn't have withdrawal effects very much. And so the company said, our drug's the best. All the other drugs are terrible for you. Our ones are safe to stop. The trick in that study was Prozac leaves the blood more slowly, and it can take 6 weeks for you to see withdrawal effects. So 1 week was too short. So it was sort of in the post, and they missed the post. And so that has entered guidelines, and that means that doctors think you can just stop Prozac and there's no issue. But actually, when you stop Prozac, the issues are in the post. They're going to come and get you in a few weeks, and that happens all the time. And that's because of that bottom left, the pharmacokinetics. The drugs basically take weeks to leave the body rather than just days. Tapering, I'll show you that with a graph in the next slide, that going down by linear amounts causes big trouble. And that's why it makes sense to do it in a slightly more careful way. In America, there's various options for tapering. There's a solution. You can get compounded capsules from a compounding pharmacy. We use that a lot in Outro. And to start with, you can split tablets in half, but that won't get you all the way down. But it's good to have as an option to start with. So normally I need to use my mouse cursor to explain this graph. So hopefully I can explain it with just my words. I'm looking at the left graph. What I'm showing you here is imaging of the brain of people taking different doses of Prozac. So the x-axis is dose of Prozac, 5, 10, 15, 20. And the y-axis is really effect on the brain. It's about serotonin, but the main point is its effect on the brain. And the main point of this black line, this curved line, is it's not a straight line relationship. So doubling the dose from 10 to 20 doesn't double the effect on the brain. In fact, if you sort of go to the y-axis, going from 10 to 20, it's a very small effect. And even a little tiny dose, like 2 milligrams, if you trace that up from 2 on the x-axis, it actually intersects with the y-axis on about 40%. It has about half the effect of 60 milligrams. So this tiny little dose that doctors might laugh about and call homeopathic actually has a very big effect on the brain. And the reason for this is the technical term is the law of mass action. And it basically means when there's not much drug in the system, all the receptors for the drug are open for business. So every milligram of drug has a big effect on the brain, so it goes up very steeply. A bit like the game of musical chairs, where it's easy to find a chair at the beginning of the game. As there's more and more drug in the system, there's less and less chairs available, and so every extra milligram of drug has less and less effect, and so you get this diminishing kind of law of diminishing returns. And this shape is called a hyperbola. So understanding that makes it easy to understand what happens when you go down your medication in the way that a lot of doctors recommend. They might say, you've got a 20 milligram tablet, why don't you take 3/4 of it by splitting it into quarters, then take a half, then take a quarter, then stop. So go 20, 15, 10, 5, 0. It sounds like it makes sense. It's easy to do with the tablets, but it causes huge problems. Because when you go from 20 to 15, you can see on the y-axis, there's only a little tiny difference between the effect on the brain. When you go from 15 to 10, it's a bit bigger. Some people can already find that pretty unpleasant to make those reductions, but some people find it okay. 10 to 5, it's double the size in terms of effect on the brain on the y-axis. When you go from 5 to 0, it's like jumping off a cliff. Going from 5 to 0 has more than 20 times the effect of going from 20 to 15. It's a bit like imagine walking down that path. Starts off like a garden path. You can skip along it, gets steeper, turns into a cliff, and you fall off it. And doctors that are not aware of that think the person has relapse, they need the drug, they're in pieces. And so if you go to the right-hand curve, what I've done here is rather than reducing the dose by even amounts of effect, so even changes in dose, it makes more sense to reduce this by even amounts of effect on the brain. And so I've drawn 4 horizontal lines separated on the y-axis. And that corresponds, if you look at the x-axis, to smaller and smaller size dose reductions, down to this teeny weeny little dose that I think is something like 0.5 milligrams before stopping. In other words, you're going to go down slower and slower as the curve gets steeper and steeper. And because this curve is called a hyperbola, this pattern of tapering is called hyperbolic tapering. And it's basically the core of what we do at Outro in order to minimize people's withdrawal effects. So I've basically turned I've turned that graph into a table, so it's a bit easier to see. This is a page from a textbook that I wrote called the Mortality Prescribing Guidelines, and this would be a taper that I would consider fairly fast over a few months for someone who didn't have major troubles coming off the drug. And you can see you go down 40, 20, 10, 5. So pretty similar to what other doctors do. But after that, there's a whole set of steps for that last bit, 3, 1.8, 1.1, 0.6, and then even a tiny little fraction of a dose. And you could use liquids. You could try skipping doses because Prozac has a longer half-life. That's an example of a fast taper. People who have even more trouble coming off, this is a slower taper. Again, at the beginning, you can go quicker, 40, 20, 15, 10. Below that, there's even more steps. Again, all the way down, there's a second column, all the way down to 0.1 milligram. So you're really going, that last very steep part of the curve, you're going as slowly as you possibly can. And of course, if people have trouble, you can go even slower than this. There's also a slow taper plan. Oh, there it is. 3 columns, all the way down to tiny fractions of a dose, just to show how long it can take people to come off these drugs, up to 3 years if people have serious trouble. So a very rough rule of thumb is for people that have very low risk factors, they haven't been on the drug too long, they've come off easily before, it hasn't been a big deal, they may be able to go down at 15 or 20% of their dose each month. And when I say a percent, I mean of the last dose. So it gets smaller and smaller as you get to lower doses. If someone has middle level risk factors, 10% per month, but with people with serious trouble coming off, they may need to go as slow as 5% of their dose per month.
So there was a question in the chat earlier actually about this. How does age typically affect? So I know we always talk about how duration of use has a pretty significant effect on severity of withdrawal symptoms and potentially too the rate of reduction that best fits that patient. How does age, if it does, play a role in choosing the right pace for dose reduction plans?
Yeah, it's a really good question. The answer is, we talk about, so the risk factors that are recognized for withdrawal are longer use, higher risk. Certain drugs, higher risk. Higher dose, slightly higher risk. Trouble in the past, likely to have trouble in the future. That's basically all the studies that have been done. There hasn't been a lot looking at age, gender, genes. There's a few findings, none of it very strong. But I've got to say my impression is that age makes it harder a bit. I don't want to say it makes it impossible, but running a marathon is easier at 20 than it is at 70 for most people. I mean, there's the occasional, I was a very unfit 20-year-old, maybe there are some 7-year-olds that could have beaten me, but in general, age is probably makes it a bit harder. So, if someone's trying to work out, should I do 10 or 5, and they felt, that they're a bit older, a bit more frail, that would be a reason to go a bit slower, I think. So, okay. So maybe I've already answered a few of these, but I'll talk to them, and then there'll be more time for questions in the chat. So I think I've made the point. Prozac is not self-tapering. It has the same withdrawals as other drugs. In some ways, it can be more confusing because if you have a drug with a short half-life, that means it comes out of your body quickly. You kind of know in a day or two, I've gone too fast. Prozac is a bit more confusing because it may be 2 months before you work out what's going on, and that means you may not put it together. I think a lot of people don't connect coming off Prozac to withdrawal because it's not as closely connected in time. If you take an antibiotic and you feel sick the next day, it's obvious it's the antibiotic. If it hit you 2 months later, you wouldn't kind of work it out. So I think it can be even more confusing. Um, I've talked about Seraphim. It's just Prozac. It's just Fluoxetine again repackaged in a pink pill. For apparently the ladies like pink is the idea from the manufacturer. Um, uh, it's got the same withdrawal effects. I very much worry about this on and off because going on and off a drug can often lead to escalating withdrawal effects. I'm not sure if that's been happening to people with Seraphim. I don't know any research about it, but I'd
It,
be concerned.
I believe it was rescinded. It was taken off the market. Like Eli Lilly
Was
had
it?
an application out for it. Yeah, in like 2024. I studied it when I was very interested in how drugs get approved.
Right,
Seraphim came up and fascinated me because it was essentially the same compound as Prozac, but it would have given them extended patent exclusivity for a different
right.
indication. But it ended up not getting distributed anymore, to my understanding. If anyone
Okay,
in the chat knows any better, let me know. But
okay, that's good to know. Yeah,
that's
yeah.
from what I remember.
That's it's called evergreening. They find a new indication to keep their drug kind of on making money. Um, what are common withdrawal symptoms and protracted withdrawal symptoms with Prozac? I mean, they're pretty much the same as all other drugs, as all other antidepressants. So the same headache, dizziness, trouble with concentration, panic attacks, derealization, depersonalization, suicidality, all those awful symptoms. Very similar between different drugs in the SSRI class. Um, does protracted withdrawal occur more often with Prozac use? I don't think so. But what does happen more often with Prozac use is probably the delayed onset withdrawal effects. So delayed onset effects can occur for actually almost any drug, even the short-acting ones. But Prozac is notorious for, the withdrawal symptoms being in the post. Um, it's a good question about protracted withdrawal. The only drug I know that is more commonly caused by protracted withdrawal is probably Paxil, and so I think Prozac is sort of around, has the
Hmm.
same risk as other drugs. So I think it's not a free ride. It's not this self-tapering, wonderland that the manufacturer would have you believe. It's got exactly the same risks as other drugs.
Yep. And we have not had our Paxil webinar yet for anyone in the chat who's curious to learn more about it. I will send everyone an email when we do have that one coming up. And just so everyone knows for visibility, we have 13 minutes left on the call. We were taking a lot of the questions throughout the presentation. So if there's anything specifically you want covered, drop it in the chat. Otherwise, we have a couple more slides to get through and you can keep sending in those questions. We can try to get through as many as we can.
Okay. So, this brings us to outro. We were basically trying to put all these things together in one kind of clinical service, where rather than having people need to go to Facebook groups to get off drugs that doctors have prescribed, to provide a medical service that will help people to come off. Um, the mainstay of what we offer at Outro is a personalised hyperbolic tapering plan. We have a regular, people see the same nurse practitioner month to month. If they have any trouble in between, they can contact them via message, so no one is left floundering around. I think that's one of the key things that we do. Is if people get into trouble, we can intercede very quickly rather than letting people float around. We spend a lot of time working out which compounding pharmacies know what they're doing and getting people the drugs that they need to make it easy to come off the drugs, which is a huge practical barrier. And we have a suite of different lifestyle medicine supports that people can use in the process of coming off to kind of buffer the problems they can experience. So, what does it look like to come through Outro? We assess people for their eligibility. We ask about why they came on the drug, why they went on the drugs in the first place, what their life is like at the moment, what sort of stresses exist, how they've tried to come off in the past, what's happened, what their intentions are, why they're coming off. We'd look into, their risk factors, and we would try to work out, what is a good place to start tapering based on kind of a risk calculator that I've worked on. It's not perfect. It's a place to start, basically dividing people into low, high, and medium risk. And then we spend a lot of time carefully following people up to see what rate suits them, working out, do we need to slow things down? Can we speed things up? What other support do they need, to try and work out what rate people can come off at, and getting them the medications that they need, whether that's a liquid or capsules that are compounded or small tablets in order to help them come off. And that's the general trajectory of people coming off, and we'll support them through the entire process if they need it. My geography skills are not very good, so Emma can tell you which states we exist in.
Yes. Sorry, there's so many questions coming up in the chat, which is great, and I'm duly multitasking. Okay, so we are currently in Washington, California, Colorado, Texas, Florida, and New York as of last Wednesday, which is great. So I also saw 2 people in the chat ask, can you guys let us know when you're available in New York? We are available in New York, so come by virtually because we don't have an in-person site. Come onto our site, and if you're interested in tapering with us, book a discovery call or initial consultation, and you can talk through with one of the clinicians. The care team can walk you through what we do, how we can work with you, and we can get started. What about North Carolina? Not yet, Tammy. Sorry. So this is the point in the chat where we can do the discussion. If you are interested in getting started with Outro, you're eligible, you can go ahead and scan the QR code and book your initial consultation. That'll take you straight to the Outro landing page. Yes, our services are for ages 18 and older, Steve. Patricia, I'm not sure when we're going to be available in Arizona. So this is me live answering some questions in the chat. And then for Mark, with the last couple minutes. Okay, so we're going to do some rapid questions here.
Yep.
Jenna said, I stabilized on Prozac after a horrific withdrawal from Lexapro. I'm sorry to hear that, Jenna. I'm terrified of trying again. Is Prozac easier to get off of due to the longer half-life?
Yes and no. I mean, I think from what I've said, it's not a free ride. I guess the thing to say to you is the way to come off it is to come off it very slowly. I guess if you had a catastrophic withdrawal from Lexapro, it's because you come off it quickly. If you come off an antidepressant slowly, it's a very different story to coming off it quickly. So, sort of like asking, I was on the top of a building, I jumped off, it was awful. Will it be the same if I walk down the stairs? And the answer is not generally. I'd be very cautious if you had a hard time, but it's not the same. It depends on how you do it.
I'm muting myself because I'm typing in the chat, but also Sarah just asked if we offer opportunities for other Outro members to get together and connect. Yes, so we did a pilot for a peer support program, and we're actually relaunching it. So we will be getting that opportunity also because there's so much support that comes with being connected with people that can understand exactly what you're going through. And it's great to have a support system from family and from loved ones and from a therapist. But it's different when you can also see and be heard from people that have gone through or going through the same thing as you. So yes, we will be relaunching our peer support program. Another question, I believe this was from Tammy. Can you suggest ways to address memory loss or foggy brain during withdrawal? I'm worried that it'll be permanent. This is a really important topic that we always get asked about. Even I get asked about this on discovery calls. I know our clinicians get asked this in the initial consultation. It's also something that we often get asked when followed by recommendations or for supplements of sorts. Mark, you can take it away there, but that's the preface for everyone else in the chat.
Right. All right. I might take a couple of minutes to answer that because it is very common. I had terrible issues with concentration and memory in withdrawal, so I totally empathise with what the question is about. I mean, I think to step back, I think that withdrawal effects that you get in withdrawal coming off these drugs, there's very little you can do about it except to go more slowly. So the analogy that I would use is, I think coming off these drugs is like going up a mountain. You get altitude sickness if you do it too quickly. So if you rush from sea level to the top of Everest in 2 days, you will get terrible altitude sickness. You've had headaches, dizziness, you'll be very sick. If you go from sea level to the top of Everest in 2 years, you'll have almost no trouble. The same with coming off these drugs. If you come off them very quickly, you're going to get terrible withdrawal effects. If you come off them slowly, the withdrawal effects will be much more spread out over time, so much less severe. That's true for cognitive problems, headaches, dizziness, anxiety, etc. So really the only way is to slow down your taper or to take a pause so your brain can get used to things. Everyone wants to know what is the drug or supplement to take to speed things up. And I really think, just like with altitude sickness, that doesn't really exist. You cannot shoot up a mountain by taking a whole bunch of drugs. Your body just, it can or it cannot adapt to that change in pressure. And it's an important feedback, I would say. If you start developing altitude sickness, you should slow down your rate of ascent in a mountain. The same with withdrawal effects. You should take it as a feedback that your system cannot handle that rate of change and just slow it down. And I think by trying to take other drugs or supplements to try to suppress it, you will lose that signal if they work, and most of the time they don't work. So I think people spend a lot of money on supplements. Most of that leaves, in their urine, and I don't think it has a huge effect on their brain because you just cannot speed up the rate at which your brain is changing its receptor levels by giving it further drugs or supplements. So I think people find that very disappointing to hear, but it's really, only going slower.
Yeah, I think something else to add to that too, and we talked about this, Mark, on our last webinar, so 2 weeks ago, is that it's not a one size fits all. So for someone like Nicole in the chat wrote that they found it especially helpful to use nootropics, I think that's great. If you find something that works for you and makes you feel like it's helping you get through the challenges of recovering from antidepressant withdrawal. Personally, and we talked about this as well, I found a lot of solace in addressing the concentration issues and overall antsiness that I experienced with working out. So phenomenally physically active. So with Outro, we're not going to be prescribing per se any specific supplement or any specific activity. It's how you come to us and express interest in things you're interested in exploring. And we support that because we also see that it's not a one size fits all, and that people will find comfort, solace, and strength or empowerment through different exercises, be it psychologically or physically in my case. That's kind of all I want to say on that topic too, because I get it all the time as well. And I think you'll find something that works for you. You just have to be open to exploring. One last question here, and I also find this pretty interesting. My doctor suggested a course of TMS treatment to help support my hyperbolic Prozac taper. Anecdotally, have you ever found this to be true at all? I haven't heard about this before, Mark, so I'm interested to hear what you have to say on it as well.
Yeah, there's some questions that I'm not sure what the answer to is, but this is not one of them. I can say with great confidence I've never heard anybody say it's been helpful to them to come off their drugs. I mean, I'm a bit... So I think, again, it's worth... So just to follow with what Emma has said, I think there are things that you can do to take the edge off withdrawal. If there are things that keep you calm, if that's exercise, or mindfulness, I think that can be useful. But, ultimately what is happening in the body, in the brain, is your brain is getting used to the drug not being there. So all the receptor changes that have occurred whilst you're taking the drug have to reverse. So you're talking about, up or down regulating receptors. You can't just, you sort of can't prod the brain to do that. So this idea that you could give a magnet to sort of speed up the brain healing is very fantastical, I would say, very far-fetched. I think that I sort of give the example of if you break your leg, what can you do to speed up the healing of your leg? Okay, you put the leg back together, you protect it from further injury, you eat a normal diet, you have enough calcium, but basically there's nothing you can do to speed it up. There's a certain rate at which new bone cells will grow and old bone cells get rid of, and there's new vessels formed. It's an evolutionary process, termed evolution. You can't sort of speed it up. And I think, unfortunately, that's the same for coming off antidepressants and for the nervous system recovering from the drugs. You cannot really speed it up. And so I've learned the people that do the best are people that respect how long it can take to come off safely. And so I think that all these other things, I think TMS, if you go on to search in Google, there's a whole group of people that have had all sorts of injuries from TMS, tinnitus, headaches, because you are putting a magnet across a very delicate organ. So I'd be very cautious with that.
I think that's a great place for us to close off here. I want to let everyone know in the audience that I deeply appreciate your time with us, committing to 60 minutes again, hearing me and Mark talk. It's wonderful that we get to do this, because I think a really important part of what Outro wants to stand for is closing the education gap and the awareness, and letting people know that not just that our service exists, but that they're not suffering alone, and that their symptoms and what they're experiencing on this journey is shared amongst a community like we're seeing in this chat. But thank you all for coming in, asking all these questions, found it super helpful. And we'll see you next week. All right, bye everyone.